Okay, so I've already plugged in your height, your weight, your gender, and your race. Um, when we do the spirometry, you're going to make a tight seal around that mouthpiece and plug your nose so that no air escapes from your nose. And then you're going to take 4 normal breaths. And then on the 5th one, you're going to take a deep breath in, and then you're going to blast it out, and you're going to keep blowing, keep blowing, keep blowing until you have no air left in your lungs.
Okay.
Okay, you ready?
Yeah.
Okay, 4 normal breaths. On this next one, take a deep breath in. Blast it out as hard as you can. Keep blowing, keep blowing, keep blowing, keep blowing, keep blowing. Keep going. All right. It says good. So we're going to do it again. You ready? 4 normal breaths. Deep breath in and blast it out. Keep blowing, keep blowing, keep blowing. Keep going. Good. Okay, we're going to do it again. 4 normal breaths. Okay. Take a deep breath in and blast it out. Blast it out. There you go. Keep blowing, keep blowing, keep blowing, keep blowing, keep blowing, keep blowing, keep blowing. Good. Okay, that was a good one. So we need to do it one more time because the last one you didn't put enough effort into it. One more time. 4 normal breaths. Deep breath in, blast it out. There you go. Keep going, keep going, keep going, keep going, keep going. Good. Okay, that's 3 good ones. So if we hit result, there we go. So it says your FEV1 was 85% predicted, which is good because it's over 80. Your FVC was 78% predicted. And your FEV1 to FVC was 108% predicted. So that one was really good. So it doesn't look like you have an obstructive disorder.
I'm awful close. So now I understand a little bit more about why this is such a valuable tool for the diagnosis of COPD. How often do you check that?
It's checked on an as-needed basis. The goals of COPD assessment are to determine the severity of the disease, its impact on the patient's health status, and the risk of future events. Future events are things like exacerbations, hospital admissions, or death, and we're going to use those things to guide therapy. Okay, we're going to assess the symptoms, the degree of airflow limitation, which we use spirometry to do that, and we're going to assess the risk of exacerbations and the comorbidities separately. Symptoms are assessed by validated questionnaires such as the COPD assessment test, or the CAT. I have a copy of it here for you.
Thank you.
Or the clinical COPD questionnaire, the CCQ, are recommended for a comprehensive assessment of symptoms. The Modified British Medical Research Council scale provides only an assessment of breathlessness. Risks of exacerbations are assessed. An exacerbation of COPD is defined as an acute event characterized by worsening of the patient's respiratory symptoms beyond normal day-to-day variations and leads to a change in medication. The best predictor of having frequent exacerbations is a history of previous treated events. The risk of exacerbations also increases as airflow limitation worsens. Hospitalization for a COPD exacerbation is associated with a poor prognosis with increased risk of death. Comorbidities are also assessed. Cardiovascular disease, osteoporosis, depression, and anxiety, skeletal muscle dysfunction, metabolic syndrome, and lung cancer are among other diseases occur frequently in COPD patients. These comorbid conditions may influence mortality and hospitalizations and should be looked for routinely and treated appropriately.